And our last speaker of the session is Bob Kirkcaldy from the CDC.
All right, thanks, Ted, and thank you for the organizers and to Mark for inviting me to speak. And thank you all for hanging in. I know there's probably a lot of hungry stomachs out there. Well, hopefully, maybe it was strategic in putting a gonorrhea talk right around lunchtime to sort of squelch people's appetite. But what as Ted mentioned, I'm with the Division of STD Prevention at CDC, and I'm going to be discussing surveillance of Neisseria gonorrhea antibiotic resistance. And so what I'm going to do in the time I have is to give you a brief but broad overview of gonorrhea, and then talk about issues of antibiotic resistance in Neisseria gonorrhea, and then discuss how we do surveillance of Neisseria gonorrhea resistance and how those data have informed policy. And I'm going to situate those discussions within the at least prevailing narrative arc about Neisseria gonorrhea resistance and epidemiologically how it seems to develop and spread. And I'll end with some conclusions. So gonorrhea, as many of you know, is caused by the bacteria Neisseria gonorrhea, which is an ancient disease. And it's still with us. It's the second most common reportable infection in the US, with over 300,000 cases reported, at least in 2010 and in the last several years. And as you know, it's transmitted sexually, but also can be transmitted perinatally if a woman is pregnant and is infected with gonorrhea. We know that prompt treatment with antibiotics limits disease and prevents onward disease transmission. And many of the cases of gonorrhea are asymptomatic, especially in women or at certain anatomic sites. But when symptoms do occur, they're usually at the site of infection and usually associated with pain or discharge. And these are the clinical sites of infection, generally where the inoculation occurs. So in women, on the left, infection can cause inflammation of the urethra, the cervix, urethritis or cervicitis, and also rectal infection and pharyngitis if infection occurs in the throat. And in men, also pharyngitis can occur in addition to urethritis and rectal infection. Now, pharyngitis, cervicitis, and rectal infections are most often asymptomatic. Urethritis in men is most commonly symptomatic and brings men in for care. So why we care about gonorrhea are really the adverse consequences of this infection. And this slide outlines some of these. There are reproductive complications such as Bartholin's gland abscesses, epididymitis, which is inflammation of the epididymis, which sits behind the testicles, and PID in women, which causes pelvic inflammatory disease, chronic pelvic pain, ectopic pregnancy, which can be life-threatening, and infertility. Luckily, in the US, disseminated gonococcal infection is quite rare, as is neonatal blindness, although in resource-limited settings it still occurs. And especially for men who have sex with men, we worry about the facilitation of HIV transmission, which can occur if one of the partners is HIV infected. Now, this slide, just as some background, shows rates of gonorrhea since reporting began in 1941. And we see quite a bit of variability, so an increase in the 1970s, which may in part reflect changes in test technology, but also could have been increased disease transmission, but also a sharp decline in the 1980s. And there was a screening program that was implemented in the 1970s. And you see in the last, really probably 20 years or so, the 1990s and 2000s, a flattening and a plateauing of disease rates, but also what has been a slow, steady decline, such that in 2009, where we had our lowest rates we've had in history. However, in 2010, I don't know if I can get the arrow, in 2010, we have seen a slight increase. And although we have had historic low rates, rates in some populations and geographic areas are unacceptably high, such as this slide demonstrates gonorrhea rates by race ethnicity for the last several years. And you see that by the yellow line along the top, gonorrhea rates among African Americans are unacceptably high, often 15 to 20 times higher than among white Americans. And gonorrhea is also clustered geographically in the US, and this slide shows rates by county, such that the dark blue counties have rates of more than 100 per 100,000. And you see a large clustering in the southeastern U.S. And I want to touch briefly on diagnostic testing before I get to issues of resistance, because it plays in and speaks to the future of resistance surveillance. And I'll start with culture. Culture is one of our oldest modalities. As you probably know, it's the cultivation of a live organism through a swab taken from the pharynx, the urethra, the rectum. And as you can see from the image, and that'll be the only graphic image I have, I promise, will be, in case of a male urethral swab, it can be invasive, it can be painful. Also, the organism is very fussy, and it requires CO2 enrichment. So things have changed a little bit, but generally you have to have the culture plates in a CO2-enriched environment. You see in the middle here the candle jars, where the candle would need to be in there to extinguish all the oxygen. So you can imagine it's not the easiest test to perform. And because of that, our culture capacity in the U.S. has dwindled dramatically. Few clinicians and laboratories are able to do culture at this time. And this is important because this is really how we do resistance testing in the U.S. And the reason the culture has dwindled is because of the availability of nucleic acid amplification tests, or NATs, which have been wonderful from a public health perspective, but are difficult because you cannot do resistance testing with these. And these, basically, you're looking for genetic material, and they can be done on urine specimens. They can be done on self-collected vaginal swabs. So not necessarily invasive, and they're also automated. And they're very good, very sensitive, and they've allowed screening to go outside of clinical settings, such as outreach centers and other places. But with the advent of nucleic acid amplification tests, or NATs, we're having fewer and fewer availability of resistance testing. And this table shows that this is among public health laboratories in the U.S., so not even the private sector. You see that just from 2000 to 2007, 18% of labs were able to do culture in 2007. Now only 5% are able to do culture in 2007. So now I'll move to antibiotic resistance in Neisseria gonorrhoeae. And treatment of gonorrhea has been complicated by the development of antibiotic resistance really since the dawn of the antibiotic era. And Mark alluded to this in his opening, where we estimate that 95% treatment efficacy is required for control and prevention of onward transmission. So historically, we've had this 5% threshold, where if resistance rises above 5%, then treatment with that agent is no longer recommended. And this is a challenging bacteria to address because it mutates rapidly, it readily shares its own genetic material, takes in other material, both from other Neisseria species and also from other bacteria. And chromosomal mutations result in stepwise declines in susceptibility, as we'll see, and also the acquisition of plasmids can result in the rapid development of high-level resistance. And this timeline I will use as a scaffolding for the rest of the talk as sort of a narrative for how Neisseria gonorrhoeae has developed resistance, and truly multi-drug resistance, since the 30s. So in the 1930s, as you know, the sulfa drugs, the sulfonamides, were developed and were proven effective for gonorrhea. But really in rapid time, really within a decade, resistance emerged to these agents. But luckily we had penicillin, and a dosage of 200,000 units was used at that time. But during the 1950s and 60s, incremental chromosomal mutations resulted in declining susceptibility, requiring dose escalation. So upwards of 4.8 million units were required by the early 1970s. However, by the late 1970s and early 80s, what was called PPNG, or penicillinase-producing Neisseria gonorrhoeae, developed. And I'll show you a bit about the history of this. Really, the penicillinase destroys the penicillin molecule, rendering it completely ineffective. And it appears that this, perhaps similar to what we heard about this morning with malaria, appeared to originate in Southeast Asia and spread globally, which is a story we'll see again and again with this organism. And also, tetracycline resistance emerged. So I want to take a few minutes just to describe the emergence of PPNG and our surveillance of that, and how our surveillance has improved over time, allowing us to detect these changes more rapidly and in closer detail. So the first cases of PPNG occurred or reported at least in 1976 in a simultaneous report in The Lancet, sort of side-by-side reports of two case reports. And one of them was a British woman with PID, and the other was a male patient who had failed treatment with penicillin. And importantly, he was diagnosed to the U.S. Air Force Medical Center in California and had reported recent travel to Southeast Asia. So during this time, after these two cases were identified, a lot of work was being done looking at further isolates. And it appeared that in Asia, at least, in Southeast Asia, the prevalence was already quite high. And these are data from Singapore, the percentage of Neisseria gonorrhoeae infections that were PPNG that had been collected since 75 through 79. And you see that this is women in the general public, men in the general public, female commercial sex workers, and male commercial sex workers. And you see just during the time period of 1977 to 1978, there was a really dramatic increase in prevalence, and which continued really to 1979. And if we're looking at a 5% threshold for change, a change from 0 virtually to 35% prevalence is really quite dramatic. So similar data were also found in other Southeast Asian countries, and by 1979, these are the countries that were reporting cases of PPNG. And what's interesting is that epidemiologically and microbiologically, there appeared to be two separate foci which gave rise to nearly simultaneous but independent emergences of PPNG, both in West Africa and Ghana and Cote d'Ivoire, and in Southeast Asia. And really, it appeared to be the Southeast Asian strain that spread globally, at least spread through the U.S., at least due in part through service members who were based or coming back through Southeast Asia. And this narrative is also supported by some of our data in the U.S., which is the distribution of PPNG cases in the U.S. This shows the number of cases during this time period, I guess this 4-year time period. And the yellow dots are less than 10 cases in a state. The larger orange dots are 10 to 20 cases, and the larger red dots are 20 or more. And we see that the number of cases in California and also in Hawaii and Guam really dwarf what's going on in the rest of the country. And many of these early cases also had travel links to Southeast Asia. I don't have a follow-up slide, but generally from here, PPNG became endemic in many urban areas before spreading nationally. So recognizing the continued development of resistance of this organism and the need for a rational, objective way to determine treatment options, in 1986, CDC helped establish GISP, which was a national surveillance system for gonococcal resistance. And as some insist on saying GISP because it's gonococcal isolate, but in terms of GISP, it's the objectives are to monitor Neisseria gonorrhoeae antibiotic susceptibility trends and really to inform treatment options and treatment recommendations. And it's a national sentinel surveillance system, meaning it's in sentinel locations throughout the U.S. It's not everywhere, but it's in 29 STD clinics. And because of the trends I showed you with PPNG, there was oversampling in the West and Hawaii in relation to where most of the gonorrhea morbidity is, which, as I highlighted, was in the Southeast. And something important to know about GISP is it's been highly effective with monitoring trends and showing prevalence, but because it's not everywhere and because the susceptibility test takes time, it's not an early detection, so it's not going to be able to pick up the first few cases of resistant organisms that enter the country. And increasingly, that's becoming more and more important as we lose treatment options. So in terms of sampling, from the 29 STD clinics that we work with, cultures are obtained from the first 25 men with gonococcal urethritis, and resistance testing is done by 5 regional laboratories that we collaborate with. And this is a map of where our sites are. So you see we do have broad geographic coverage throughout the U.S. The red dots are the clinic sites, and the yellow stars are the laboratories who conduct our susceptibility testing. And susceptibility testing is done by agar dilution, which, if you're familiar with that methodology, can be laborious and can take at times up to 1 or 2 weeks to get a result. So in addition to the isolates that we collect, we also collect epidemiologic and demographic data on the patients who the isolates are taken from. That includes race, ethnicity, age, sexual orientation, HIV status, travel. And with these data, we're able to look at resistance patterns that emerge within not just broad geographic areas, but also within patient populations, or are there risk factors, at least epidemiologic risk factors, that could account for resistance. These are the antibiotics that we test for. And we have, so for many of these antibiotics, we have nearly 20 years of trend data. And we collect about 5,000 isolates per year. So it's quite a rich data source. And I should also say that in addition to GISP, GISP is part of a global, I don't want to say network, we're trying to foster greater collaboration within these systems. But there are multiple systems that are conducting surveillance, usually laboratory-based surveillance that collect a convenient sample of whatever winds up in the reference laboratory throughout the world. So I want to now describe, okay, thank you, how surveillance informs policy. So as I said, in '86 we established GISP, and these were the recommended drugs at that time. So 2 cephalosporins or 2 fluoroquinolones. One of these was to be used for gonorrhea, a one-time dose. So we had 2 classes. But during this time, fluoroquinolone resistance was starting to emerge in East Asia. And these are data from China. We see a rapid increase in the prevalence of QRNG, of quinolone resistance, from 20% to nearly 80% over the course of 4 years. And a similar pattern was seen in Japan during the 1990s. So we anticipated it would travel to the US as well. And indeed, it followed a similar course to PPNG, where it first became prevalent in Hawaii. So it was during and GISP at this time allowed us to monitor it in relatively real time. So by 1999, the prevalence had reached over 5%, and fluoroquinolones from a national policy were no longer recommended to be used in Hawaii. And quinolone resistance then emerged in California, and a policy was made at that time that gonorrhea diagnosed in California not be treated with fluoroquinolones. Men who have sex with men was the next population in which QRNG emerged, and fluoroquinolones were no longer to be used there. And then QRNG disseminated nationally, and by 2007, fluoroquinolones were no longer to be used with anyone with gonorrhea in the US. And these data changed the way patients were treated. So these are data from Debbie Dowell that showed the percentage of patients with GC who are treated with fluoroquinolones after the April 2007 guidelines were updated. So you see with the dotted line. So you see a significant decline after that. People still are treated with fluoroquinolones, but it's better. So we're now left with just one class of cephalosporins. And this is really where I'll wind up my talk. We're at a crisis where we have few good treatment options available, and really one class of antibiotics remaining for treatment for gonorrhea. Not surprisingly, we're already starting to see declining cephalosporin susceptibility in East Asia and also in the US. And I'll just show you briefly in terms of the cephalosporin. Cefixime is an oral agent, and in 2001 was the first case of a cefixime treatment failure for gonorrhea. And then those have been seen also in other Asian countries, and very worryingly, they're starting to be seen in Europe as well. We're also starting to see increasing MICs to the cephalosporins, again, first in East Asia and now in Australia and the US and Europe. And you may have heard the quote-unquote gonococcal superbug. This summer, there was an isolate that was identified in 2009 from a female commercial sex worker that was resistant to ceftriaxone, which is our last big gun, an injectable antibiotic. And these are data from GISP that we published in July that shows that just between 2006 to 2010, the percentage of isolates with elevated MICs to cefixime increased significantly. And worryingly, this trend is most pronounced in the West and most pronounced among men who have sex with men. So following a similar pattern in which it appears to be, history appears to be repeating itself indeed. So in conclusion, we know that Neisseria gonorrhoeae has developed resistance to each of the antibiotics used for treatment, and we anticipate that cephalosporin resistance will soon, not soon, at least hopefully will be delayed, but will emerge in the US. And culture is necessary for antibiotic susceptibility testing at this time, but as I mentioned, with the advent of gnats and the challenge of doing culture, we have a significant decline in culture capacity, and that's really been hampering surveillance and the detection of resistance outside of GISP. But despite that, surveillance of Neisseria gonorrhoeae resistance is critical, particularly in this era of declining treatment options. And hopefully we'll be able to detect resistance early within our current system, but also we are able to provide evidence-based rationale for treatment recommendations. And hopefully we can use something we haven't explored a lot, but hope to in some of our collaborations, particularly with Mark and his colleagues, are using some of our GISP data to help inform transmission of resistance throughout the gonococcal population and hopefully to slow that down. So thank you.